All right. So I probably don't need to convince you of this, but TBI is a big global problem. In the U.S. alone, 2.5 million ED visits every year for traumatic brain injury, almost 300,000 hospitalizations and 56,000 deaths as of 2013. Throughout most of our lives, men are more susceptible to suffering traumatic brain injury. It's for a variety of reasons. And that's sustained until really the very end of life. And a lot of this probably has to do with men being more impulsive, more involved in things that are physical. Their occupations are more dangerous. But you see this difference becomes particularly pronounced during teenage and young adulthood years. What are the causes of TBI, at least in the U.S.? So this is a graph looking at emergency room visits. So these are people who come to the ER. They don't get hospitalized. They get sent home. And if you look at kids 0 to 4, the vast majority of them are coming to the ED because of falls. So this is a proxy, in other words, for minor, very mild or non-existent TBI. They hit their head. They didn't actually get TBI, right? Because this is ICD-9 and ICD-10 code based. So people are loose and sloppy with those. Some of the patients, they didn't actually have a brain injury. They just got a hard hit to their head. Other ones had very mild TBI, concussion, in other words, they got sent home. So for very young children under 4, it falls. As kids become a little bit more mobile, it's things falling on them. That's what this struck by against is, which is about even with them falling from things. And then in the teenage years, things get spread out a little bit more. Assaults become more prominent. They're still getting hit by having things fall on them somehow. And then motor vehicle related accidents, either getting hit by a motor vehicle or being inside the motor vehicle when you collide becomes more of an issue. And that stays pretty much the same up until middle age. Then as we age, we start falling more, unfortunately. So we start life in diapers falling down, and we kind of end life in diapers falling down. As for more severe TBI, and this is deaths, which is a proxy for more severe TBI, obviously. You can see that orange is taking up a lot more of each of these graphs. There's a lot of force involved in motor vehicle accidents. For kids less than 4, about 40% of severe TBI is due to child abuse, basically. Another 25–30% is due to motor vehicle collisions. Kids get more mobile, they run into the street. They're unrestrained, improperly restrained in a car. That's why you have this peak of deaths related to motor vehicles in 5 to 14-year-olds. And then people start to get sad and they start to kill themselves. So for adults, suicide takes up about 30 to 40% of traumatic brain injuries, and then the falls come again. Balance gets bad when we get older. So there are a variety of ways to classify TBI. TBI it's kind of I'm not really sure that it should be a single topic. I guess this is a historical problem that's been lumped together as one thing, and that's just based on the fact that your head is getting smashed. But it's really heterogeneous mishmash of different things. You can approach it from injury mechanism, and we'll get to the details of these things in the next few slides. How severe the brain injury is, and then you can categorize it by different aspects of what happened anatomically during that traumatic brain injury. So if you classify it by mechanism, that's pretty basic. Penetrating versus not recently, particularly since the era of the war in Iraq, people have been creating a separate category for blast injuries. Some of the sequelae may be different. The rest of this talk is really going to focus on non-penetrating. There's really not much you can do for most patients with penetrating head. I'm not going to go into this too much. I'll just keep it up there for a second. And so you can see it in the video. There are a lot of different forces involved in traumatic brain injury, and which forces you're subject to. When something hit, you decelerated. Was there blast involved? Not important once you receive the patient in the ICU. The only thing I'll mention is about the coup and contra coup. I thought this was a good graphic representation of what's happening. Right? Normally, your brain is sort of floating in a sea of CSF. You know, it's not in contact with the skull. It's not like it's squished in there full. There are a couple of tether points, but, you know, one way to think of it is floating in CSF. So something comes and smashes your skull, and your skull accelerates. You know, initially your brain hasn't moved yet. Skull accelerates into the brain, and there's a little bit of deformation of the skull, a little temporary deformation, so you get some direct impact right under the impact site. The acceleration of the skull into the brain then accelerates the brain. And so the brain goes flying in the other direction, in the same direction, and you get this contra coup, so to speak, injury on the exact opposite side. And that this is a very commonly seen. In fact, you more commonly see the contra coup injury than the coup injury. It's not that there's not an injury there on the coup side, it's just that it may be of the invisible type of injury, which I'll tell you more about the invisible injuries as we go through this. And if anybody has any questions at any point during this, you know, please just raise your hand and stop. I don't think we'll take up the entire time on this. We'll have plenty of time. You can also classify TBI. Yes?
Sorry, do you see that same sort of pattern? I mean, I imagine not, but like, how would it look like with a rotational type instead of like a linear acceleration to acceleration?
Yeah, so that's that will somewhat come up in the other slides. With rotational forces, you're not having this direct impact of bone against brain. However, different parts of the brain, which have different densities and different parts which may be tethered versus other ones that are not, will accelerate and decelerate at different rates. So there will be specific areas of the brain where you'll get tearing of neurons and sort of invisible injury, diffuse, you know, axonal injury, so to speak. But I'll tell you more about that in a few slides.
Thanks.
So I guess to sum up the answer, you'll just get more invisible injury as opposed to the visible injuries that we're going to discuss in the next few slides. Yeah, so you can break down TBI based on severity, and there are clinical scales, and really the only one that people use is GCS. It's not a particularly good scale. The inter-rater reliability is not that great, but it's been around for a really, really long time. That's what they've been using in studies for a really long time, and that's what people are going to continue to use. I don't think there's any effort to dislodge the GCS. And in fact, I think the people who came up with the GCS like a year or two ago, they made a website to show people how to do the GCS. They didn't really change anything in the GCS. They changed like one or two words around, and that's it. GCS is here to stay. There are also a couple of radiographic scales, like the Marshall CT scale and the Rotterdam CT scale. You don't have to remember that, but if you're reading something about TBI and they're talking about the Marshall classification, that's just a scale that looks at whether it's a diffuse kind of injury, you know, diffuse axonal injury, how much swelling there is basically, and grading 1 to 4, and then there are two types that are more focal injuries. So most studies that are breaking down GCS, TBI based on severity, will do it in this fashion. Mild is a GCS of 3 to 15, 15 being normal, obviously. Moderate, 9 to 12, and severe, 3 to 8. And then yet another way to break down TBI is based on what you see on imaging. You know, patients will have their own unique mix of these pathologies, but there may be one that is predominant. We'll go through some pictures. Pictures are always nice and talks. It gives you something that you fill up a slide easily, and people like to stare at pictures. So here's a depressed skull fracture. I'm not sure you learned anything by looking at this picture, but I get to put a picture there. And then, you know, obviously the brain is getting injured under the depressed skull fracture because the skull is supposed to prevent your brain from directly being exposed to forces, but now you're having bone chips smashed into the brain. Even if it doesn't go through the dura, through the meninges, you've had that impact, and you may have invisible injury. Epidural hematoma, we talked about this yesterday. It's lens-shaped. These are usually high-pressure large arterial bleeders. They're not going to stop on their own. Classic story is you get a head injury, severe concussion, so you're knocked out, completely knocked out for a while. You wake up, and then you deteriorate again as the hemorrhage accumulates. So just because somebody's okay initially, they got knocked out, they woke up, doesn't mean they're going to stay that way. That's why people go to the hospital and why they're supposed to get observed. But if you're sitting off in the corner in the ED, in a very busy ED, you're not found until you have bilaterally known pupils, that's not going to work really. So you got to keep an eye on these patients. Subdural hematoma, we talked about this yesterday too. Shape is different, right? It's concave on this side, it's not lens shaped. These are lower pressure, usually venous origin, but they can still get quite large acutely. You can see this person has a bunch of midline shift. And then for whatever reason, even with mild traumatic brain injury, if the whack was mild, I mean, say not mild by GCS terms, when people get subdurals for whatever reason, even though there's no violation of the meninges, they'll get edema in the underlying brain. That takes up more space. So that's why sometimes, like for example, in this picture, the amount of midline shift seems a little bit more than the actual thickness of the subdural. That's because there's edema in the brain underneath it. Traumatic subarachnoid hemorrhage has a different pattern than aneurysmal subarachnoid hemorrhage. And most aneurysms are on the circle of Willis. So that rupturing thing is at the base of the brain, and that's where your blood will be, in the cisterns, in the basal cisterns. Traumatic subarachnoid hemorrhage is more typically on the convexities, on the surface of the brain. Although rarely it can give you this picture with just blood in the base of the brain, and then you'll usually do vascular imaging anyway. Because you can also obviously, and I see this once or twice a year, you can get traumatic brain injury because of aneurysmal subarachnoid hemorrhage, right? Many patients pass out when they hemorrhage and they fall and smash their head. So you can have both. And you definitely don't want to miss any aneurysm. This is very high morbidity and mortality to not securing the aneurysm and be bleeding. Contusion, which is different from hematoma, which that's kind of easier to explain. I'll go over that first. In hematoma, you just have a pure ball of blood. All tissue is excluded. It takes up space. Contusion is different. In contusion, you have tiny areas of bleeding interspersed with normal tissue, macroscopically interspersed with normal tissue, and then on a microscopic level, erythrocytes infiltrating through normal tissue. So this isn't, I wouldn't say this is the most typical contusion, because you have, I guess you could say, a dozen or more tiny contusions there. A more common one you would see is something that looks like a looks like a hematoma that's not as dense as this, and you see its size, but then you look around at at the surrounding structures, and there's like no displacement of those structures, because it's not a hematoma that is taking up new space and pushed everything out of the way. It's interspersed with that normal tissue. But contusions, unlike these hematomas, have this propensity to keep bleeding. And beyond the normal 24 hours we think of as being the window where things can expand. I've seen contusions blossom 48, 72 hours later. So you're usually a little bit more conservative with subcu heparin, and you want to watch these patients. You definitely don't want to send somebody with a contusion home. They need to stay in the hospital for a few days. Contusions can turn into a hematoma. That's often what happens when they expand, is that one of these tiny parts of the contusion turned into a hematoma. Intraventricular hemorrhage, you can get isolated intraventricular hemorrhage, but anybody know, well, I just pointed to it by mistake, but anybody notice any other pathology on this CT?
Yeah.
Yeah, there's a thin subdural here, which is not of any consequence at that point, but could expand. And I don't know if this is subarachnoid or subdural. Probably subdural, because it's not going into the sulcus right here, right? And that's how you differentiate subarachnoid from subdural if you're unsure, is that subdurals won't go into the sulci. Subarachnoid space does go into the sulci. The sulci are subarachnoid space, so that blood would go into the sulci. And axonal injury, I mean, there are images. You can see axonal injury on imaging, but typically not. It's mostly invisible, even when you do have imaging findings. CT is rather insensitive for it. You can see petechial hemorrhages around midline structures, or at the gray-white junction, the junction of the cortex and the white matter. But I wouldn't bank on that. MRI is more sensitive. Some specific sequences that look for microscopic amounts of paramagnetic stuff, of iron, of heme. and this thing called diffusion tensor imaging that looks at the integrity of the white matter tract. But for the most part, it's a clinical diagnosis. You'll have a patient with TBI who's just much worse off than their imaging for unclear reasons, and that's because they have axonal injury. You don't have to chase the imaging for that. There's nothing you can do about this specifically you can do to cure their sheared axons. Patients with diffuse axonal injury, depending on how severe it is, they have substantial increase in morbidity. You can take care of mass lesions. You can take a subdural out, epidural out, intraparenchymal hemorrhage, take that out. You do decompression, but if you have widespread shearing of your axons, there's nothing we could do about that other than treat the symptoms, treat the ICP, and there's nothing we can do to aid in repair. So any questions about this anatomical classification or the different components of TBI? Oh no, yeah, one more thing. Independently, you can get vascular injury. Depending on what the nature is of the trauma, you can have gross vessel disruption, either transection of vessels or more commonly dissection of intracranial or extracranial vessels, cervical vessels. We're talking about microscopic injury to the brain, and the same thing happens to the vessels. There's no reason that the microvasculature would not be subject to the same forces. So for a variety of reasons, you'll get leaky capillaries, which will lead to more edema formation and impaired autoregulation. The arterioles are not working right, which can have some secondary effects, which we'll discuss. So I think I just threw this in there because somebody asked about this curve yesterday, and I said it would be in here, but it wasn't. So this is the normal cerebral autoregulation curve. You can think of this, just to make it simpler, we'll say this is systolic blood pressure down here on the horizontal axis and regional cerebral blood flow on the vertical axis. So for a normal person, over a pretty wide range, let's say systolic of 80 to 220, you can maintain the exact same cerebral blood flow in any given area. And you do that by changing the size of your arterioles, right? So as the blood pressure gets higher, the arterioles will constrict to increase resistance to flow and keep that flow exactly what it needs to be. But if you go above 220, that's beyond the capabilities of the musculature of your arterioles. You start kind of blowing them open. If you go below 80, then you have passive collapse and hypoperfusion. But in somebody with TBI, you may have either a narrowing of that plateau, a narrowing of the region where they have actual autoregulation, or just a shifting of it to the right, such that you need higher blood pressures for them to be autoregulating appropriately. And I don't think we may not have time to talk about it today, but there are ways that you can kind of figure out the shape of this plateau or where the plateau is at the bedside, so that you're not hypoperfusing them. I think there was some question yesterday in those multiple choice questions we're doing that I guess they were kind of trying to be humorous about preventing epilepsy and with primary prevention. So, as such, there's really not much you can do about the initial injury except, take off skull or take out hematomas, right? That's all really more about primary prevention, not getting people into accidents in the first place, making cars safer. But there are all these secondary injuries that take place that may be targets for treatment, and people do things to try to prevent them or ameliorate their effects. We don't really have any evidence to support any of that, but that's what's done. Or, at best, we're operating off observational stuff. Some randomized controlled trials have been done for some of the stuff, and we'll discuss some of those trials, but they've been poorly done. It's just very difficult to do studies for traumatic brain injury. And we'll discuss that more when we discuss the rescue ICP trial. But it's thought that a lot of the secondary injury is due to ischemia. I'll come back to that in a moment. There are a lot of factors that play into the development of ischemia after traumatic brain injury. There's also non-ischemic energy failure. You have mitochondrial failure. It's poorly understood why, and there's nothing you could do to reverse that. There's not, for the ischemia stuff, we have some putative treatments, some things that we think might work. For the mitochondrial failure, you got nothing. And then the development of edema, which will contribute to increases in ICP, which will lead to hypoperfusion. But, again, we don't really have anything that we're aware of that can reduce edema formation. Right? So they tried out steroids, that didn't work. So here are some of the factors that go into the development of ischemic secondary injury. A lot of them are supply related, failed autoregulation I mentioned, development of intracranial hypertension, which can lead to a compartment syndrome, basically. Right? If the perfusion pressure of this compartment, if the ICP is high enough and the MAP is low enough, you just won't get enough blood flow, and you'll start having neuronal loss due to ischemia, particularly around already existing injuries, because those neurons are already injured and they're very vulnerable. They may have been on the border of dying, and they're at the point where they're starting to repair themselves, and they will be less able to tolerate ischemia. A variety of systemic factors, which you normally would want to try to avoid anyway, hypoglycemia, hypocapnia, right, because it causes arterial or vasoconstriction and can lead to ischemia, systemic hypoxia, hypotension, right, we discussed that yesterday. Systolic less than 90 or hypoxia on presentation has good quality evidence to support it's highly correlated with a poor outcome. We can say that. We don't really know if reversing it can change things. In animal models of TBI, there's also microvascular spasm. So the microvasculature, the arterioles develop vasospasm, not the macrovessels. It's unclear how much of a contributor that is to ischemia in humans. And in animals, there's also sort of a localized DIC. So you have thrombosis happening in arterioles, just in the brain itself and not elsewhere. And then there are demand issues. These patients often get central fevers, and for every degree Celsius that their brain temperature goes up, the metabolic demand of the brain goes up about 8 to 10%, 7 to 10%. And if they have all those supply issues, for example, failed autoregulation, they may not be able to meet that additional demand. And then there may be ongoing subclinical seizures, which, when an area of the brain is seizing, it's pegged to its maximal metabolic rate, and that may tip it over into becoming ischemic and dying. So I didn't know where to throw this in. These are the Brain Trauma Foundation guidelines. I'm not going to go through them all. I'm going to just leave this slide on here for a couple of minutes so that when you go through the video, you can look through these things individually. I just highlighted a few of them. A couple of things of note. Why is this covering up this? Let's get rid of this. Okay. There's almost nothing that is a level 1 recommendation in the Brain Trauma Foundation guidelines. So almost everything is a level 3 recommendation. Actually, the only thing that's a level 1 recommendation is don't give steroids. Steroids, especially high-dose methylprednisolone, is associated with increased mortality. Everything else is 2A, 2B, or 3. So here's one of the ones I highlighted. Decompressive craniectomy, not recommended to improve outcomes. Only thing they say it shows has been demonstrated to reduce ICP and minimize days in the ICU. So you can save lives, not going to improve functional outcomes. Well, they don't say the save lives thing here, but a subsequent trial, they mentioned this year, a trial that came out after they made their guidelines showed that's what it showed. We discussed this a little bit yesterday. They don't recommend not severe, what is the word I'm trying to think of, aggressive hyperventilation because it causes ischemia. And they recommend that if you're going to hyperventilate the patient for a prolonged period of time, that you use some modality which is telling you about oxygen delivery to the brain to make sure that you're not causing ischemia. SJO2 is jugular bulb oximetry, right? So you're sort of putting a backward central line. You'll usually use a pediatric trivolumen with an oximetric tip. And the jugular bulb is outpatching at the top of the very beginning of the jugular, the internal jugular. So you want to advance it up to there. You want to get it as high as possible because you want to exclude any extracranial blood, which is usually highly saturated because your face is not using that much oxygen. And you want to try to sample as pure brain blood as you can. And just like central venous saturation or mixed O2 venous sat, the extraction of oxygen is linked with your perfusion or your supply and your demand, because it could be either issue. And so if you're overly hyperventilating somebody and causing ischemia, the jugular bulb sat will be low. And the same thing with the brain interstitial oxygen. That's what that other thing is, the BTPO2. That's not the usual abbreviation people use for that. But you basically have a probe sitting in the interstitium of the brain between the delivery system, your vessels, and the receivers, the neurons. And so the level there of oxygen, the oxygen tension there is reflecting that balance between supply and demand. And obviously that number will drop if you're making them ischemic. Here are their recommendations for monitoring. They choose their words very carefully. Management of severe TBI patients using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. And notice the things they leave out. They don't mention anything about improving outcomes, improving functional outcomes rather, nor do they mention anything about long-term mortality. That's all the evidence we have right now. I think a lot of it is just our quality of studies is very poor. The only real randomized controlled trial we have, again, I mentioned yesterday, was this, I couldn't remember the name yesterday, but the name of the trial is Best Trip. It was conducted mostly in Ecuador and an adjacent country. We don't know much about the pre-hospital care. They were all funneled to 3 or 4 tertiary care centers, and it took a while for many of the patients to get there. So that's a wild card. You don't really know what kind of care they were getting at the time. And then the management was just kind of weird. The control group, the non-ICP monitor group, just got a lot of treatment. They got 3 times the amount of treatment that the ICP monitor group got, and a lot more head CTs. So I don't really see how that's cost effective. The reason they did it in Ecuador is because you can't do such a trial in Western countries because physicians don't believe there's equipoise, right? You have to believe that there's an equal chance that not having an ICP monitor can be okay for the patient versus having an ICP monitor. And people in the United States and Europe don't believe such a thing. Just everybody manages patients with an ICP monitor. If you told a doctor, yeah, I have this patient with severe TBI, I'm going to try to manage him without an ICP monitor, we're just going to get frequent head CTs and do neuro exams a lot, they would say you're fucking crazy. So that's why they have to do this trial in Ecuador, because their standard does not include use of ICP monitors. Their standard is really frequent neuro exams and frequent CAT scans, and treat based on that. To me, when I read that trial, it was more like they're just giving scattershot treatment. They're like severely over-treating them, and it showed that it was equal to using ICP monitoring. ICP monitoring was not harmful. But anyway, we don't have the evidence to support that ICP monitoring can improve outcome. This is all we got. It's short-term mortality.
Would it decrease the cost?
I mean, I guess it decreased the cost in Ecuador, right? Because they don't have the infrastructure set up. They don't have people trained to use those things. But I don't think it would decrease the cost in the U.S. if you're getting more CAT scans and you're using more treatment. And I don't know what the length of stay difference was in this Best Trip trial, but I vaguely recall that the non-ICP monitor group had a longer ICU length of stay. So then that's not cheaper. We have no reason to stop using ICP monitors.
Yeah.
The only reason that somebody could ever come up with it is the neurosurgeons at home and they don't want to come in. Because if some neurosurgeons in the hospital, there's just no excuse for them not to put in an ICP monitor. You need ICP. It's interesting because then they make a recommendation that you should monitor the CPP, but you can't do that with an ICP monitor. So I think then they're kind of telling you to put an ICP monitor in. And then as far as more advanced cerebral monitoring, because there's a variety of probes you can put into the brain parenchyma to monitor different things, blood flow, lactate, pyruvate, glucose, glycerol. It's a thing called microdialysis. You get interstitial fluid out of the brain, and the pore size, you have different kilodalton pore sizes, so you can measure whatever the hell you want in it, but they're machined by default. The machine the company supplies, you can measure glycerol, glutamate, lactate, pyruvate, and glucose. So some people measure that, interstitial oxygen, and there are 2 different technologies to measure that, and then of course ICP monitoring is another intraparenchymal probe. Some people use depth electrodes. I don't really think there's much of a purpose in it other beyond research. but you occasionally will get a person who's seizing on the depth electrode but not on their surface EEG. And then there's jugular bulb monitoring, which is not in your brain parenchyma, but it's invasive. But the only one that they find any evidence to support, and it's a level 3 recommendation, is jugular bulb monitoring. And based on the data that's available, they support its use to reduce mortality and improve outcome at 3 and 6 months, which is more than they can say for intracranial pressure monitoring. But it's fallen out of favor. It's a real pain in the butt modality. You need to recalibrate it repeatedly. If the positioning of it is not good, you're not going to get your continuous measurement, like if you're up against bone. Eventually, the tip of the thing starts getting sludged, so then you're not getting a good signal anymore. If you didn't put it up far enough, and you're getting all this external jugular blood, all this facial and orbits blood coming into the IJ, which is highly saturated, then the number is just meaningless. You're giving yourself this false sense of security. So a lot of places just stop using it, particularly when interstitial oximetry came around, because then they could just stick this probe in the brain and it gives them a reliable continuous number. Although it's only giving you numbers, the data it's giving you is only from a very small area. So anyway, out of all that, the only thing they recommend is jugular bulb monitoring, and it's a pretty weak recommendation. Thresholds. This was a very interesting one. This came up on rounds with somebody very recently. Was it you last week, or no, somebody else? That was somebody who was trained by another person for some absurd thing, which was incorrect. It was not consistent with this. But when we went to look it up, this was new to me too. It's new in their 4th edition. They have different blood pressure thresholds for people of different ages. And this is all based on one very large observational study, which is retrospective, it's not a prospective study. So I would take this with a grain of salt, and that's why they say level 3. But keep the systolic above 100 for patients 50 to 69 years old, or at greater than 110 for patients 15 to 49 years old, or more than 70 years old. Nobody's going to remember this, and I don't think anybody's going to act on this.
Only 50 to 69 is greater than 100. Everybody else, yes. 110.
Yeah, and kids are excluded from this. What's that?
What does it mean, 59 and 60? Well, we don't 50 to 69. You do 100, and then everybody else is 110. And how is 69 better than 70?
I mean, they have to choose some sort of cutoffs for their analyses.
Okay. But
I think, it's silly for them to put things like this. They make people take their guidelines less seriously when they put nonsense in here like that. They could have just said, put everybody above 110.
Yeah.
10. The variability is like.
Yeah, I mean, first of all, if you walk into a SICU and you look at where the transducer is placed in most patients, it's more than 10 millimeters of mercury off. The number of times I walk in and adjusted the height of the blood pressure transducer and changed their blood pressure by 20 millimeters of mercury, it's just very common. I don't think that's isolated to the SICU. It's been like that in other places I've been. Where I trained, I mean, I've never seen this anywhere else, but the nurses did something that I thought was more reliable. They taped the blood pressure transducer to the side of their arm, which made it almost always leveled with their heart. So there was no issue. You change the level of the bed, it doesn't matter. It's sloppier because there are more cables and lines in the bed. But I brought it up to the nurses here, and they scoffed at me. Anyway. Thresholds, they're getting a little silly with the thresholds. Treating ICP greater than 22 is recommended because values above this level are associated with increased mortality. Everybody's already used to doing 20. Nobody's going to change based on that. Recommended target CPP, they changed this. In their 3rd edition, they said keep it above 50 because 50 is widely recognized that if you're below 50, you're ischemic. Even, many normal people will be ischemic. And they recommended that you keep it between 60 and 70. Which again, we need continuous ICP monitoring in order to monitor CPP. You can't do it with an EVD because you just get a spot number once an hour. And then whatever CPP is on the monitor for the next hour, well, it doesn't mean anything. Interesting. She got a specific direct call. The reason they specifically recommended 60 to 70 is that there was an old trial done of I don't remember all the details of the trial, but one group had higher CPP goals. I think they, instead of controlling their ICP, they tried to just keep their CPP high, and not be as aggressive with specifically ICP reduction, as long as the CPP was good. And there was a much higher rate of ARDS in that high CPP group. Whether it was really ARDS or just pulmonary hypertension was beating up their heart with pressors, I don't know, but they had more respiratory complications. So that's why higher CPPs are frowned upon. There may be things from invasive monitoring that make you choose a higher CPP, but you shouldn't just blanket make everybody CPP 80, 90, whatever, because there are potential harms. And then if you're using jugular bulb monitoring, they recommend keeping it above 50 or doing something if it goes below 50. In normal humans, it can be as low as 45, but they want to give a little cushion. So, you know, aside from the Brain Trauma Foundation guidelines, which are limited because the data is limited, you use surgery if you need it. If there's a subdural or an epidural or a big parenchymal clot, take it out. If there's too much edema and you don't think medical management is going to be able to take care of the increased ICP, you can remove bone. They can either do bifrontal craniectomy, they can do a hemicraniectomy of varying sizes. And the Brain Trauma Foundation specifically recommends a large one if you're going to do it. Because if you do a small hemicraniectomy, you have brain mushrooming out of the defect. And then what happens is the bone edge is kind of cutting into the brain and causing more injury. So right, I was saying you have bifrontal, they take off both frontal bones. You have a hemicraniectomy, and then there's a thing called a bucket handle craniectomy. It's basically a bilateral hemicraniectomy, and they leave the center strip because you have the superior sagittal sinus under there. You can't take that off. The most recent and best conducted trial for decompressive hemicraniectomy in TBI is called Rescue ICP. I told you about another one yesterday called DECRA, but that was only very specifically for patients with diffuse axonal injury. In this Rescue ICP trial, I think I have some slides on it in here. Yeah. In the Rescue ICP trial, they took any kind of TBI patient, and that TBI patient could have already had surgery for a mass lesion, but they just had to have had the bone on at that time. And they had to have failed tier 1 treatments, which are not really treatments. They're just kind of like tier 0 treatments. Keep the head of the bed has to be up. They have to be on a ventilator. They have to be sedated. You have to be monitoring their ICP. If the ICP was above 20, you had to enact stage 2 treatments, which are the actual treatments, which include putting a ventriculostomy, they say inotropes, but they really probably mean pressors, and you know what they mean is managing their CPP, hyperosmolar therapy. I don't know why the hell I have this in here. That's like ancient neurosurgeon treatments, and they include hypothermia as a stage 2, which is interesting. I think in many European countries they use it earlier than we use it in the U.S. And so if you fail these, and they define failure as ICP over 25 for 1 to 12 hours after that, which that's kind of long, 12 hours, then you would be randomized to surgery or just the medical treatment group. In the medical treatment group, you can do whatever you want, including taking the bone off, unfortunately. And that's the problem. One of the major problems with all TBI trials is there's a lot of crossover. And then as for what surgery they do, they have the choice between a big hemicraniectomy or a bifrontal craniectomy. I don't think they could do this bucket handle craniectomy. So, you know, I mentioned crossover is a problem. So here you have the medical group. 37% of the medical group got a decompressive hemicraniectomy. Most of the patients in the surgical group got a bifrontal, which for whatever reason in Montefiore they don't do. I think it's just an issue of it's not a trauma center. Neurosurgeons who work at trauma centers are more used to that. But it just makes a lot more sense. If your whole brain is swollen, why would you take one side off? And so just so that everything is being distorted and pushed out of one side, it just makes more sense to just let it be bilateral. And then what did they do in the medical group? You know, right, because the ICP is still high, is almost all of them got put into a barbiturate coma. That's how they deal with it, which is pretty toxic. And so their primary outcome was functional outcome at 6 months. And, you know, in a lot of neuro trials, we're used to seeing the modified Rankin scale, but they use something that's a little bit more fine-grained called the extended Glasgow outcome scale. which includes death, vegetative state, lower severe disability, lower is worse than upper, upper severe disability, lower and upper moderate disability, lower good recovery, upper good recovery. They define good outcome as the blues and greens, which is intuitive, I guess, and yellow and orange and black are bad colors. So primary outcome was EGOS at 6 months, greens and blues, and this is medical group, this is surgical group. There's basically no difference. All they did was take a bunch of people who would have died and turned them into either vegetables or severely disabled people. Things looked a little bit better at 12 months, which was their secondary endpoint. You could see that the green and blue zone is slightly larger, but maybe like 5%, less than 5% difference. It's not statistically significant. And, you know, again, you've got more vegetables and more lower severe and upper severe disability. So even though those Brain Trauma Foundation guidelines didn't take that trial into account, it didn't really change anything. You know, reduced mortality, didn't improve patient outcome, but there was a lot of crossover. You know, 40% of the medical group got decompression anyway. What would have happened if they really had true isolation between those groups? Who knows? You know, maybe they didn't find any effect on morbidity, on functional outcomes because there was so much crossover. Maintenance of normothermia, you'll learn a lot of, I mean, we always talk about that when you rotate through the SICU. This is really for any kind of acute brain injury. In animals, in all the different animal models of traumatic brain injury, if you raise their body temperature after the brain injury, they have much more neuronal loss, their functional outcomes are worse. And in humans, in observational studies, in traumatic brain injury, the higher their temperature is, even when they control for all other factors of severity, their outcome is worse with a higher temperature. So we think, based on that controlling their temperature can prevent some of that worsening or improve their outcome. And so there are many ways to go about that. First tier is medications, acetaminophen, ibuprofen, obviously. Some of these patients you don't want to give ibuprofen because of bleeding risk. And then there's surface devices and intravascular devices to control temperature. But we don't have any prospective evidence supporting this. A lot of low quality, very low quality trials, and then a good quality trial, but with a weird protocol called Eurotherm, published in New England Journal a few years ago, where they used hypothermia as a very early treatment, like as almost a stage 1, like an early stage 2 treatment. And they used it early on, and for most patients, they only had 48 hours. They only used it in patients with increased ICP, as opposed to older trials that just gave it to everybody with TBI. They were trying to use it as a neuroprotectant. It definitely doesn't work as that. You know, all the trials that looked at, oh, you're coming to the hospital with TBI, you don't have ICP yet, we're just going to give you all 48 hours of hypothermia. That didn't work. It doesn't protect their neurons. It definitely reduces ICP, you know, which it did in this Eurotherm trial, and every other trial that's looked at it. We just don't have any data to support its improving functional outcomes. EEG, pretty widespread. It's the same deal as everything else I'm saying. We have observational studies that show there are lots of seizures in people with severe TBI, that having non-convulsive seizures is correlated with a worse outcome if you control for all other risk factors for poor outcome. And taking all that into account, we treat seizures aggressively. Again, you know, there are many people out there who believe that we shouldn't be doing that the seizures are a marker of poor outcome, marker of severity of injury, but most places will treat aggressively. We don't have the data to actually support its whether or not it improves outcomes. And invasive monitoring we'll talk about in the future, because that will take an hour by itself, and we are out of time. Any questions? I mean, a lot of traumatic brain injury management boils down to things you have no control over, which the surgeon has to do, and ICP management. And then not allowing severe physiologic derangements. Don't let them become hypoxic. Don't let them become hypotensive. Be aware of the CPP. Just because their MAP is greater than 65 doesn't mean their brain is being appropriately perfused, right? If their ICP is 20 and their MAP is 65, that means their CPP is 45. And that's ischemic. And then being aware that things could be happening to them that you can't see, so you got to get EEG consider invasive monitoring, and don't let them have fevers. Okay, if there are no questions, we're done. Thank you. Okay, and stop recording, right?